welcome to the UK.
Thank you so much. I'll have Srinivas introduce the panel here, and then I'll let him take over.
Okay, excellent. Hello, Srinivas.
Go ahead, Srinivas. Can you introduce the panel?
Waiting to see the newer delivery system, new valve, which you are doing it. It just got approved in India, we were told. So we are eagerly wanting to see your case.
Excellent. So shall I start?
Please, sir.
Okay, so welcome to Belfast, Northern Ireland, to the Royal Victoria Hospital. It's a great pleasure and honor to be part of your meeting. I'm joined today with my friend and colleague, Dr. Andrew McNeice, and the whole cath lab team here. And we hope we will be able to share with you an interesting case. We will go through the case in detail. We will then show you where we are at the moment, and then hopefully we'll be able to show you the new generation or the next generation Abbott Navitor valve with its Flexnav delivery system. So without further ado, I'm going to get Andrew to present the case for us and take you through the steps we have done so far. Andrew.
Okay, thanks, Ganesh. So yes, welcome to Belfast, everybody. It's a pleasure to present this case to you. So we have an 86-year-old female who has symptomatic severe aortic stenosis. She has progressive exertional dystonia with an NYHA classification of 2. A transthoracic echo confirmed severe aortic stenosis with a mean gradient of 47 and a valve area of 0.81 centimeters squared. She's got normal LV function and a rise in NT-proBNP recently in keeping with her symptoms. She has, in terms of comorbidity, she's got chronic kidney disease, and she's recently been investigated for an anemia and was found to have a colonic tumor and is awaiting surgery. So after a heart team discussion, the consensus was for a transfemoral TAVI to treat her aortic stenosis and also to facilitate timely surgery. She's had a gated CT as part of her workup. And this is interesting and shows off probably some of the benefits of the Navitor valve, which we can talk about in a bit more detail. She's got an aortic annulus perimeter of 78.5 millimeters. So she's on the borderline between a 27 and a 29 millimeter Navitor valve. She's got a very eccentric aortic annulus, again, which is another discussion point, which we should talk about later. So her minimum diameter is 20 millimeters, but her maximum is 29 millimeters. The eccentricity index is 0.30. And again, her LVOT is eccentric. The minimum diameter is 16.6 millimeters and a maximum of 29 millimeters. You can see that it's a tri-leaflet valve. The non-coronary cusp is heavily calcified, and that extends into the LVOT. The coronary height is fine, both 16 and 15 millimeters respectively. Okay, next slide, please. Eccentric calcific disease. So the idea is this fills in diastole and fills the gaps in the annulus that can't normally be filled by other cuffs. Over time, this seal will endothelialize and will provide a permanent seal. Next slide, please. And finally, the other iteration in terms of delivery, it's the Flexnav delivery system we're using today. So it's got compared to previous Portico iterations, it's got a reduced insertion profile. In this case, for a 29 millimeter valve at 16 French, it's a sheathless approach with an integrated sheath. But the biggest game changer we've had is its deliverability, and that's mainly because of its hydrophilic coating. And we have found it just travels so easily compared to previous iterations or against competitors. It's definitely our most deliverable delivery system. It's got a stability layer that leads to improved trackability, and the capsule that the valve is in is hydrophilic and it is flexible. Next slide, please.
We'll come back to the data maybe after the case. Andrew, what do you think?
Yeah, sounds good.
Okay, so let's go to the case now. I'll just explain to you what we've done so far. The patient has a temporary wire and she is fully awake and conscious. I've gone down the left femoral access for the 6 French sheath, and then I put the large bore sheath through the right femoral artery. For pre-closure, I put 1 ProGlide and 1 ProStar device, giving you 3 sutures to obtain hemostasis after TAVI. There's a 16 French sheath already in. we have crossed the valve. Maybe, David, if you can show the playback of the crossing and the positioning of the back again. Sorry, forward one. Next image. So that's this cross, and you can see that, play that back. You can see that it was very difficult actually to cross the annulus even with the 5 French. So I tried with the AL1 catheter and it was impossible to do it. Took a JR4 diagnostic catheter and I was able to just about cross it. And then you can see that the calcification of the non-coronary cusp is really, next slide please, or next image. Really interacting with the catheter, and you can see when the wire is bouncing over the leaflet. So the pre-dilatation here, I think, will be important. Next image, please.
Can I ask you a quick question?
Absolutely. So I'm going to stop then. Question to panelists and to the chairs, please.
Sorry, just a quick question on the pre-dilatation. Do you do that routinely with Navitor, or is this based on this patient anatomy, or?
So that's a good. I routinely pre-dilate all my patients, regardless of the valve. The only valves I don't pre-dilate is if I'm going transapic with the adverts, or if it's a valve in valve, or in a patient with already moderate severe AR or severe AR. Otherwise, every other patient I pre-dilate. But the strategy I use for pre-dilatation is to pick the minimum diameter to valve to balloon choice. So in this case, patient has a minimum of 16 LVOT, 20 in the annulus. I've taken an 18, and the thought is that I think post-dilatation social carries a higher risk than pre-dilatation. So if we go down this strategy, hopefully we'll not need to post-dilate. But in this patient, I think we'll need to be aware of the risk of post-dilatation because minimum diameter of the LVOT is only 16. There's a lot of calcium around that zone. And I think minimizing the risk of trauma there will be important.
Yeah, and I think that I was just worried it's an intra-annular self-expanding valve. I was just wondering if there's a difference in strategy. And do you want to comment? I know I had somebody was calling me at that moment, but the leaflet coaptation and elliptical deployment, is there a concern with an intra-annular? I know the leaflet design of Portico is different. Do you want to comment a little bit about that?
So the original concept was Navitor or the Portico was don't put in true elliptical anatomies. What I found, and now we have some data, Francesco Bedoni's team in Milan were able to show that as well at the bench and in a modeling technique, comparing the Portico frame and the Medtronic frame, Evolut R frame. The Portico actually behaves better for forming seal in elliptical anatomies. And I think the reason is for that is because in a square inch, there's less metal in the Portico system than there is in the Evolut system, and therefore it will then oppose better and align better to ellipticity. But also remember, this technology has an external skirt, which is a unique type of skirt. It's not, nobody's done it this way, and it does fill the space. And we were part of the Portico NG study, which is the Navitor valve. We did 18 patients here. Of the 18 patients, we had only one pacemaker, and two patients had mild PVL, and the rest were all trivial or none. So the concept seems to work actually quite well in this patient group. But okay. we'll see, yeah.
Yeah, absolutely.
Okay, so
and do you sorry.
Go ahead.
You have access to different valves. How this is just being approved in India, as you said. Srinath said, how do you choose one valve over another? Is it small sinuses for coronary access? Is it hemodynamics? How do you choose one over another?
Yeah, that's a really, really important and intriguing question. I think that's something that all of us are going through now at the moment, right?
Yeah.
What to do next. And my thought is, I think it's heavily calcified not to use a balloon expandable. So there's a heavily calcified anatomy, so I would prefer not to use a balloon expandable. If it's a very small anatomy with significant calcification where I'm concerned about expansion, I may go for a supraannular technology. If a patient already has pre-existing coronary artery disease and I'm thinking of reaccessing, then I'll choose a valve that has easier options for reaccessing coronary anatomy like this one or a Sapien. So I think, where we are today, I think all the technologies in about 80% of patients, you can use them safely, effectively. And then I think that about 20% of patients where you do need to have maybe 2 or 3 different technologies on your shelf that each will have its own area of superiority.
Dr. Ganesh, I think you are saying the same indications like a core valve, but it is a better positionable or some advantages over that with this newer system?
Well, I think in terms of deliverability, this is definitely superior to any valve I've touched so far. The deliverability of this technology is really out there compared to any other technology. But in terms of anatomy, for example, I think you can easily put a Evolut Pro here and still get a really good result, you know. But I would be concerned about putting a balloon expandable. So in India, you'll have MyValve and Sapien. So I would be concerned putting a MyValve or Sapien in this anatomy. But I will have very little concerns of using either the Medtronic valve or in this case, the Navitor valve.
And post-procedure coronary access is also better.
The coronary access with this valve is easy, no question about it. So coronary access is definitely better with this valve. But, you know, I grew up with Medtronic technologies and I've never had a difficulty crossing to the coronary arteries 2-3 years down the line in patients who present acute coronary syndrome or something else. The other important that Andrew just reminded me about is this patient does have a horizontal anatomy. And I think you'll see that with this technology, the valve does seem to align a lot better to horizontal anatomy than other self-expanding technologies would.
Ganesh, would your wire selection be decided by the aortic angle? I mean, would you like to use a stronger
that's
wire?
A good point. So you'll see from the deployment technique we're going to use today, we will not use the wire at all for any positioning of the valve. I think this patient, by the way, also has quite hypertrophic left ventricle and a very small left ventricle. So I think picking, you're alluding to like using a Lundquist wire or something like that, right?
Yeah.
Or a double Lundquist.
Yeah.
So I must say, I am not a big fan of Lundquist wire. The only time I've used it is in patients where we had difficulty even crossing the valve, and then I would go to a Lundquist wire. And more frequently, I would have used it. But now this will be an interesting case because the coronary calcification is on the non-coronary side. So if we don't get a good pre-dilatation, we may have difficulty crossing the anatomy. So I've just positioned the wire now. I think in the interest of time, I am going to carry on and do the case, and then we can ask questions while we're doing it, if that's okay with you all.
Sure, absolutely. So yeah, please keep going.
So we picked a 18 balloon. So simple things, for example, I've connected a side arm flush to the side arm of the sheath we're using. So we're flushing the sheath constantly, so that minimizes thrombus formation in the sheath. I think no matter how heparinized the patient is, there's always the risk of thrombus migrating and clot migrating into the sheath. This allows us to ensure that you don't take thrombus with you when you're going up the valve. So we'll be rapid pacing in a minute. We'll just let the patient know we're going to do that. Ready for pacing in a minute? Could somebody let the patient know we'll be speeding up in a minute? So one of the advantages of doing things on local is that the patient is an excellent feedback to us about if something is not going well. The other disadvantage, obviously, is you have to be fully aware and question that the patient is fully awake and conscious. So you do need to keep them fully informed. So you can't depend everything on your anesthetist to do the job.
That's a very important point, sir. Actually, Kribir was also mentioning this. When you push something, if patient gets into pain or something, you avoid applying too much force and you avoid complications too. I think that's a very important point to mention. I think Sai also just joined. Welcome, Sai. Ganesh, his case is on. Sushil is also here. Sorry, Sushil, you were telling something.
No, I was just asking Ganesh. I didn't want to interrupt him while he's doing the BAV, but do you have an anesthesiologist or an echo person in the room, or it's just you with your cooperator and your assistant?
Me, myself, and I know. Actually, I've got Andrew with me, so he's an expert interventionist. He's a consultant cardiologist here. I have staff nurses who've been with us. Really, 2 of them have been with us from the inception of TAVI in our unit. All our staff nurses are trained to give drugs if need to, phenylephrine, adrenaline, atropine. So they've all been licensed to do that. So we don't have an anesthetist in the room. But we are a trauma unit, so for me to get an anesthetist in the room, if I have to, it takes about 5 minutes. And we are also a surgical unit, so that's that's an interesting question to ask in terms of once we start doing low risk patients, should we have the full team in the room? and we can talk about it, I guess, later on.
I guess it's also maybe different for you who've been doing it for 15 years versus somebody that's starting, I guess is my question as well.
Yeah.
You know, where they
I think safety is always important. You have to be safe first and foremost. So we're just advancing the Navitor delivery system with the Flexnav system. So all of that from there to there is just hydrophilic coated. Okay. So Andrew is just going to rotate it 360 while I advance it in. And that's it. That it goes. You know, I'm not kidding. Right? There are times where I've advanced this valve, and Andrew would have done the same. And you feel, okay, have I actually gone through something that I shouldn't have? But actually, it's so flexible. It's amazing, actually, in terms of the technology. Okay, let's see the arch a bit, off mag a bit. Maybe go to LAO 15. Yeah, I'll do. So normally we do TAVI from the, let me see the LBY actually more importantly. We do it in our hybrid room, but because of the transmission and also we have a GA list going on in the hybrid room, we have now gone to the original room where we started doing TAVIs, which is room 4. It's as big as the hybrid room, but the imaging facility is not designed for, okay, that's good. So store that. Let's go to, just stay where you are actually. So in terms of the frame alignment technique, the most important thing, I guess is true even for any other technique you use, is to make sure your pigtail is in the non-coronary sinus. So we can do that by contrast injection, or the other way to do that is to go to REO now, go to REO 15. Now she is leaking a little bit, so I'm going to be reasonably quick. And you can see that the pigtail is posterior to the catheter, so we know that it's a non-coronary sinus. So, okay, let's go back to LEO 10. Let's go to normal fluoro. Okay, that's much better, I think. So I'm going to just advance a little bit more. So as I'm advancing, Andrew's pulling the wire back to lift the nose cone away from the LVOT. We're going to start releasing the valve now. MAGA 1 maybe? Perfect, yeah. Can you all see that?
Yes, yes. So is the positioning sort of similar to what you do with core valve then? Is there a difference?
Exactly the same. No, exactly the same. Just pull the wire back a bit more. Great.
Just looking at the hemodynamics, it looks like there's a little bit of AI with crossing the valve.
Yeah, so we're just going to go quickly.
Yeah.
Okay, stop that. Stop that. Coupling on, please. Yeah, that's a lot of AI. So we're going to go reasonably quickly now. Start releasing. Keep releasing.
I think
Go a bit more late. Stop there for a second.
In the Zoom, you make the link coming from UK bigger. All other people can be smaller. Make that cath lab feed bigger, like how we do for slide sharing.
Stop. Go a bit more Leo. Okay, stop there. Coupling on. Stop there. Okay. Pacing on. Go ahead. Pacing off.
So,
okay. I'm sorry. I had to
very
do that
stable.
quickly.
The position looked very stable during deployment. Right? Sorry, go ahead,
I'm just going to let the hemodynamics recover. So the patient obviously had quite significant AR during the procedure. You saw that the hemodynamics dropped quite significantly. And I think that is due to the significant calcification, and in the BAV, even with the 18, clearly had torn the non-coronary cusp or leaflet completely away, giving effectively free AR. She is recovered quite nicely now. You can see the hemodynamics a lot better. I'm going to align the frame again to maybe come less LAO.
Ganesh, can I make one quick comment?
Go for it. Go for it. Yeah. Keep going.
So one thing that you did that I think is a great learning point is there was significant AR. So with these self-expanding valves, you know, even if it's not perfect position, he got and it ended up being perfect, but he just get the valve in before the patient becomes incredibly hypotensive, get the valve in, stabilize the patient, and then you can always recapture and reposition. But with that degree of AR, if you see the LV EDP going up and everything else, and you wait too long, the patient gets into an ischemic spiral. So I think making a quick decision and sort of saying, okay, I'm willing to readjust, I think that's important.
Absolutely. And I think, okay, so you guys can see that. So the key part of the frame alignment technique is not to go caudal or cranial in the LAO tilt. You keep going LAO until the frame, inflow portion of the frame is aligned and the pigtail is non-coronary sinus. So you can see the depth at the non-coronary sinus is about 2 to 3. The advantage of the LAO technique without caudal cranial tilt, you can see what the valve is doing in the left coronary sinus is about 4 millimeter depth. You can also see the coronary arteries filling both the left main and the RCA. And you also can see the position of the delivery system in relation to the ascending aorta. Now, what we're going to do now is to go, we have about 15 minutes, so we have plenty of time. We're going to go to the cusp overlay angulation now. So I'm going to fluoro this while we do that. Okay, so coupling off. And then you can see that the frame is still not fully aligned. So I'm going to go a bit more caudal without losing my finger. Okay, perfect. Okay, coupling on now. So you can see the depth in the non-coronary sinus is about 1 to 2. Similar to the pure LA view. And that is what I found by doing this technique, that the depth I get, the assessment of depth I get using the frame alignment technique on the LAO, pure LAO, and the RAO caudal is exactly the same. The other thing I've noticed when I'm doing, so in about consecutive cases since 1st of September, I've routinely gone to the RAO, the cusp overlay positioning. And in about a third of patients, the frame is not aligned. And I think one of the benefits of this technique is that you treat the patient on the table rather than treating the CT of a patient. And for those of you who do cusp alignment technique, when you go home tonight, try this out. You do your cusp alignment projection on the systolic image and also the diastolic CT image, and you'll see that the measurements are different, which is, again, not rocket science because the heart does move during systole and diastole. So, okay, let's go back.
Can I ask, on this view, it looks like you're on the inner curve, at least it's an RAO. Is there, do you release tension or do you do anything different at this point?
Yes, we'll go to LAO now, Sushil, and then we'll put wire back and make it more coaxial. But I like the depth. I don't think I'm going to change the positioning in terms of depth. And the wires pull back. Go to normal fluoro again, please. Okay, wires pull back, and I'm just going to, we will take one more angiogram, Andrew, before we coupling on. So these are only 10 mil shots, by the way. So you can see that by just waiting for another 5 minutes, the technology is already working. The PVL is mild, I guess. I'm going to pull the pigtail back, and we're going to release in a minute. We'll release in rapid pacing as well. You saw the pigtail was stuck in the non-coronary sinus. Okay, release a bit more. Release a bit more. Okay, pacing at 180, please. Yeah. Go ahead. Pacing off. That's fully released. Now, remember, this technology has 3 cusps to look at. So we will make sure all 3 are released. So we have 2 we can see. Go to slowly LAO, slowly RAO. And just need to find the 3rd one. Okay, that's it. So stop there. Coupling off. So you can see all 3 anchors freely. So I'm going to now gently go back to LAO and withdraw the delivery system. Now, one of the things to remember with the Navitor system is that the upper crown cells at the outflow portion is also large. So you do need to make sure the nose cone does not interact with that. You notice I've also taken the wire out early on in the system. Okay, back to AP and off mag.
So what's interesting is, despite heavy calcium, as you rotate it around, it looks like there's pretty good expansion of the valve. And
it does, doesn't it? Yeah,
maybe
yeah.
a testament to your BAV first, right?
So I must. So in the last from January 2020, okay, we didn't do as many TAVIs in 2020, but from January 2020 till now, Sushil, I've done probably 2 post-dilatation of my overall TAVI numbers, which I do think. And then again, using this technique and the pre-dilatation, consecutive cases from the 1st of September till now, which is 80. This will be 85th case. I've had only 1 pacemaker. So for those of you who are scoring the TCT abstracts, I'm submitting it as an abstract, so be nice.
No plugs allowed here.
No plugging, no plugging. It wasn't a plug, it was a direct request. Okay, so I'm going to now, we have, how many minutes? 10, 12 minutes. So I'm going to, Andrew's going to put a pigtail in. We do look at the hemodynamics, and then we'll take an aortogram again. And then if there's time, I have actually...
Can you show us how you assess whether you're aligned with the conifers, or do you do that, or?
You can. I don't do that. With this valve, I think you don't really need to do it, but certainly for...
Because it's intraannular. I see.
Yeah, it's so easy to access the coronaries. It's... Okay, pigtail, please. So we do have Usman Khan here, who's one of our senior registrars. He's actually from India, Pakistan. He's from Pakistan. He will, if we have time, he will do a quick echo as well and see what's going on. Wire out. So Usman wants
to always recross. You always recross.
Yeah, that's a good point. I mean, I must say I have always recrossed, and one of the reasons is that we usually then be part of some study somewhere, and one of the requirements of these studies is to have invasive gradient assessments.
Do you worry with these big cells when you recross that you go through this frame, or?
That's a good point as well. And usually I go with a pigtail and I don't go with a wire neat. I think that's, go to normal fluoro, please.
Sushil, I think Sai also joined. Sai has quite good remembrances of Ganesh working. Any comments, Sai?
No, Sai.
No, I'm just enjoying.
Is it good remembrances or remembrances?
good ones.
You see, he be nice to Sushil and always tries to...
I'm always nice to you.
You guys can see the gradients. You can see the conduction is narrow, complex, sinus rhythm, good separation of the aortic end diastolic pressure and the LV diastolic pressure, and there's no gradient across the valves. So what I think for the purpose of audience, I'm going to go from LAO to RAO so you can see about the frame expansion. Let's do that under fluoro. Okay, perfect. Okay, so we are going from LAO, that's fluoro across, to RAO. And so see, you're right. You can see that the valve is, despite the significant calcification and ellipticity, you get the normal, let's play that back, you get the normal elliptical changes due to the anatomy, but the valve is very well expanded. Huh?
I mean, I think one of the things that I find interesting is, my initial concern, when you feel like when you have less frame, that the radial strength will be less, but they've engineered the nitinol and the strut thickness that the radial strength is comparable to a core valve, but the cells are much larger. So I think that's intriguing. This is an example of that.
It's a cool engineering guy. The guys have done well. Okay, let's align the frame again. Less LAO actually. Keep going less. Keep going less. Keep going less. Keep going less. Less some more. Keep going until you align the frame, David. So if David as the radiographer, we have Gay and Roche, and we have Tanya from Abbott to help load the valve. I think that's everybody's mentioned. Oh, and we have Gareth, who's the... Just align the frame again. Perfect. Okay, that'll do. Coupling on. Let me see more of the LV.
Beautiful.
I think that's a nice result, no? You got no
Very
leak,
nice.
despite the significant LVOT calcification and the non-coronary sinus calcification. You can see that there's zero leak, no gradient, no conduction disturbances. We have time, so let's talk a little bit more of the data. So I'm going to go back to the data, and then you can, while Andrew is showing you the data, I'm going to close the access as well. The access is the boring part, so but I'll do it anyway. You know.
But Ganesh, you won't use echo at all in your lab?
Well, we will do it before the patient leaves the room, only to make sure there's no pericardial effusion or anything like that, but not to assess the valve functionality. We've done that invasively. We have a good hemodynamic. We have no gradient across the valve, and we have zero leak at all. So can we show the slide with the data? So this is presented by Lars Sondergaard at PCR, and it shows the EU data set of the patients who enrolled into the Portico NG study, which demonstrates both the hemodynamics and the PVL data for this patient, for these patients. You can see that at 30-day follow-up, 80% of patients had none or trace PVL only, and about 20% at mild. There was no moderate and no severe PVL. And if you look at the hemodynamics, and that's the key part, I think you can see that the mean gradients with this technology is about 8.1 and 7.4 at discharge and 30 days. You remember the mean gradient of this is similar to the supraannular technologies. And I think that's another feature of this technology. I mean, that's something we found repeatedly. It is an elliptical anatomy. You would expect for an annular functioning valve to have a much higher gradient. And, you know, in this clinical trial as well, I've done patients with elliptical anatomies, and this is what we're finding actually, which is quite nice. So let's go to, are there any other questions? We're kind of coming near time zone. Right down the leg, please.
We see Nagendra Bhupati and A.B. Mehta, sir. Any questions? Sir?
I have one question to Dr. Manoharan, sir. So what exactly is the difference between, what added advantage of this valve as compared to Evolute anatomy? The Evolute being a supraannular, it's believed to give a lesser gradient. This being a self-expanding intraannular, do you think the benefit of supraannular is lost in this valve?
So I think the benefit of supraannular is that in very small anatomies, you potentially will have lesser risk of gradient. So that head-to-head study has not been done. But so far, the advantage of this technology are that you see that, you know, despite fairly hostile landing zones, we got results that are quite acceptable. In fact, I would say excellent result. Actually, no leak, no gradient, and no conduction disturbances with a significant calcification of the LVOT. And that's, you can't, I mean, that's surgical outcome. I mean, we've got results similar to a surgical outcome in a patient who is, you know, elderly with high risk features. So I think those are the key benefits of truly supraannular versus a annular functioning valve. So you do need to look at each patient now. So one of the benefits for us as clinicians is that we now have big competitive companies trying to up the game all the time. And when they do that, they give us better, easier technologies to work with. And I think this is one of the benefits of what we do. Can we just show the hemodynamics and the ECG? And then...
And can I say, just as a junior operator and a young operator in TAVI, this is just my third year as a consultant. The big thing for me is vascular access. That was the Achilles heel. Vascular access, vascular complications, and pacing rates was the Achilles heel of TAVI as we move to lower and intermediate risk groups. So for me, using the Flexnav delivery system, it makes vascular access, I think, so much safer and less challenging. And now I think with our more novel implantation techniques, we're all starting to achieve lower pacing rates. And then the third point of why I would use a Navitor valve over an Evolut would be for coronary access in lower to intermediate risk patients. So I think those are the main features of the Navitor valve and its positive aspects. And why you would choose it. And finally, the horizontal anatomy, that was the big thing today. Definitely horizontal anatomy, I feel it's superior compared to the Evolut.
Yes, I think most of you saw, maybe we can go back to the final implant angiogram. You can see that the depth on the non-coronary and left coronary is similar in a patient with a degree angulation of almost 53 angulation. So Andrew, you brought up some really important points there. No, the angiogram, final angiogram. Yeah, that's it. So you can see that it's really symmetrical depth of implantation, whichever way you look at it. It's quite a... are there any questions?
Dr. Ganesh, after you have tried, by all means, sometimes in horizontal aorta and things like that, if the valve is quite well positioned in towards one side and looks deeper or higher than the other side, for the sake of beginners, what would you advise your strategy should be? In spite of trying all that, still it is fitting like that. What do you?
So my strategy would be to use this valve. Now, if somebody was really, truly horizontal anatomy, I think this or Sapien works very well. Now, Sapien, in this case, I think we would have almost definitely had a risk of annular rupture. If you don't have this in your technology, then using a double S curve Lundquist could help. But the other thing you can do is start high on, if you're using Medtronic Evolut R or Evolut Pro, start high in the non-coronary and don't engage the annulus until the sleeve is just about to come up. Remember, the sleeve is about 1 centimeter away from the valve. Then engage the valve to the annulus at near 0, and then let it slowly expand up to 1/3. At 1/3, advance the catheter forward. That will line the greater curvature, which is what double S curve wire will do to you. And that will then tilt the valve up to meet the left coronary. But and that will fix the extreme horizontal anatomies as well.
Thank you. That's a great point. Thank you. Many of the times, but now easy solution you are saying is this newer valve, which will help in most of the situations.
In horizontal anatomy, this is what we get. It's equal distance on both sides.
It's great.
It is. Now, this is fine. There's horizontal anatomy, and then you also have how short or long your ascending aorta is. So in this patient, the ascending aorta is just long enough for the frame to fit in nicely. If you have a very short ascending aorta or an ascending aorta that starts bending very early, no matter what technique you have, no matter what valve you have, unless you use a Sapien valve, you will be lower on the left coronary and higher in the non-coronary, if that makes sense.
Thank you, sir. Great tips, and you did it like almost like coronary angioplasty in the time allotted. You finished the case perfectly. Any final words of advice or comments on this, sir? Before we close, we are at the end of the session.
I think on behalf of all of us here, I would like to thank you for allowing us to demonstrate a new valve, new technique, and yes, in this unit, TAVI occasionally is actually much easier than a CTO case. So
thank you, sir.
So, thank you again
for obliging. Thanks for obliging our request, and even in these tough times, you showed an excellent case demonstration and for the new valve, which you are not very familiar with. Thank you once again, sir.
Thank you. I work with excellent teams, so that always helps.
Thank you, sir. Our team concept always is important, right? Thank you.
Greetings from FACS Foundation, TCT India South Asia 2021. This will bring to you the live case learnings of the Dr. Ganesh Manoharan's live case, which was a demonstration of Abbott's next generation Navitor valve system with Flexnav delivery. Initially, we've learned what are all the advantages of this newer system. This being better coating with hydrophilic coating, He felt it is better deliverable, and then 16 French, and it has a cuff all around, which can decrease paravalvular leak significantly. With a low metal to nitinol ratio, it has better expansile properties, and then with only 3 shoulder design above, it can lead to better coronary access on follow-up. It also helps in better positioning of the valve, especially in horizontal anatomy and anatomy with LVOT, calcium, and things like that. And the Flexnav system, he says, is the best, which has the best system for easy deliverability of this valve, which he felt is a great advancement over the other existing systems. And he also felt that this could lead to less of AV blocks and less of problems in post-procedure to these patients. Other important discussion which all of us want to learn, which we became wiser after this case, is when to prefer balloon expandable, when to prefer self-expanding valves. In the discussion, when we brought out this, Dr. Ganesh Manoharan felt 80% of the times we could be using any of these valves, because most of the times either of it we can do it, and we should become comfortable with each of it, and using what you are more comfortable is more important. But there are some peculiar situations in about 20% of scenarios where one could be preferring over the other. To give an example, probably if a patient has a small aortic annulus or horizontal aorta or LVOT calcium, he thought self-expanding systems could be preferred to avoid problems happening like ruptures or other problems in delivery. On the other hand, if a patient is relatively younger and he needs to better coronary access and follow-up, he felt we could use balloon expandable valves, which could have easy coronary access on the follow-up. Then he also felt that if at all you have to use a self-expanding system and still have the coronary access, then probably you could use this Abbott Flexnav system, which has the advantage of both. Then obviously what is more important was highlighted that the better hemodynamics which can happen with the supraannular systems for core valve, which has least gradients and better effective orifice areas after the deployment, which tend to give better long-term follow-up results. Horizontal aorta, then especially when you are facing these problems, he felt that the Navitor type of system, which has a better placement and then probably could be very beneficial in positioning on both sides well with a slow release. And Ganesh's team felt pre-dilatation, he does it in most of the situations, that he felt will avoid the post-dilatations, and the post-dilatation after the valve deployment dilating could have troubles like valve pop-out. So he always felt that if required, pre-dilatation is better. It will avoid problems in taking the valve in, and also will rarely get a situation where post-dilatation will be required. Then during problems in placement, when asked the question whether you one side, if the valve is seated well, when you turn it to the other side, the depth looks more, what are the tips and tricks if you have to see, he always felt that whichever side it is little on the top, then take it and then follow slow release patterns, and especially probably if you use the cuspal overlap technique and the S-shaped wire techniques, then probably this would help in right deployment of the valve in right places. Then later, effectively, they also showed the percutaneous closure of the femoral artery site, which we regularly do with the same perclose system. And finally, what he highlighted was each of us should become comfortable with one of the valve systems and keep doing cases more, and then probably 80% of the times would be able to get away. But if at all, there are some particular anatomies like horizontal aorta, smaller annulus, LVOT calcium, probably he felt that expandable valve systems could be preferred, and with difficulties in positioning and tortuosities and calcium, probably the better Flexnav system will give you easy access and easy position, better tracking of this valve in these difficult anatomies. So this was effectively shown and highlighted by Dr. Ganesh Manoharan. Thank you all, yours Dr. A. Srinivas Kumar. Hope you all enjoyed the live case and also learned this point through live case learning. Thank you.